Hi, I'm Helen Bauer, and this is the Heart of Hospice podcast. The Heart of Hospice podcast is your source for compassionate and informative discussions about hospice and end-of-life care. I'm a certified hospice and palliative care nurse with over 15 years of experience. Whether you're a caregiver, someone with a serious illness, or you simply need to know more about hospice care, this podcast is for you. Join me as we explore all the aspects of hospice, from the details of caregiving to the emotional and spiritual dimensions of end-of-life journeys. For more resources and to connect with me, visit theheartofhospice.com and find us on Facebook, Instagram, and LinkedIn. Keep listening for today's episode.
This is the Whole Care Network. Helping you tell your story one podcast at a time. Content presented in the following podcast is for information purposes only. Views and opinions expressed in this podcast are solely those of the host and guest and may not represent the views and opinions of the Whole Care Network. Always consult with your physician for any medical advice, and always consult with your attorney for any legal advice. And thank you for listening to the Whole Care Network.
This episode of The Heart of Hospice is being sponsored by Care Boss, the latest book by Jennifer O'Brien. Care Boss is the book that reminds family caregivers that they are the CEO of their loved one's care. Jennifer has served in healthcare leadership for over 35 years and was also the personal caregiver for her parents and her husband. Care Boss is written to empower caregivers, but it's more than just a book. It's a workbook and organizational tool as well. Check it out at jenniferaobrien.com.
Today's guest is psychiatrist, researcher, and author Dr. Harvey Chochinov. Dr. Chochinov is a Distinguished Professor of Psychiatry at the University of Manitoba and a senior scientist at CancerCare Manitoba Research Institute. His research in palliative care has resulted in more than 350 career publications, broaching diverse topics such as depression, quality of life, suicide, vulnerability, spirituality, and existential distress. He also has led a large program of research on dignity within the healthcare setting, which includes the development and study of dignity therapy. Dr. Chochinov is the co-founder of the Canadian Virtual Hospice and co-editor of the Handbook of Psychiatry in Palliative Medicine. His latest book, Dignity in Care, The Human Side of Medicine, was published by Oxford University Press. He's an officer in the Order of Canada and an inductee into the Canadian Medical Hall of Fame. You can find Dr. Chochinov's works at dignityInCare.ca. Today's episode is the first in a series of 2 conversations with Dr. Chochinov. It was a great discussion. Dr. Chochinov talked with me about how dignity in care benefits patients, families, and professional caregivers, so healthcare providers. We talked about how the healthcare system often dehumanizes people by turning them into patients with a medical record number and forgetting about their personhood. Dr. Chochinov also talked about the difference between healthcare and health caring. It's a really interesting concept. And one of his most powerful quotes is, people don't care how much you know, but they want to know that you care. This is a great conversation. There's a lot to learn. So stay with me for this episode and then connect back in for episode number 2 of the series. Dr. Chochinov, welcome to the Heart of Hospice podcast. I'm thrilled to have you on the show.
My pleasure.
It's great to have you. So we always start with an icebreaker question that I don't usually send to my guests ahead of time. My apologies. But we're going to take a question from the end of life deck, which is the sister deck to the death deck, if you've ever heard of them. The end of life deck is used by end of life workers to facilitate conversations about death and dying, incorporates a little bit of humor and along with some reflections. So I picked a card, not knowing you, we haven't talked before. So here's your question. Have you chosen a final resting place? And you have 3 answers to choose from. Yes, I'll be with family. B, just one place. I want to be scattered in my favorite spots. Or C, I want to be in an urn beside you so we can watch TV together. Nothing creepy about that at all. So with family, scattered, or in an urn. Those are your 3 choices.
Well, it's an interesting question because it's been part of an ongoing conversation between my wife and I for some time. So the answer will be with family. The challenge is her family is buried in one cemetery located in one part of the city. My family is buried in another cemetery in another part of the city. And what we keep trying to figure out is, so how are we going to work this out? So the answer is with family, but exactly what that will mean and how it will play out kind of remains to be seen.
I like it. At least you're having the conversation, which is more than a lot of people get to. So it's a good start.
We are having the conversation.
Excellent.
Absolutely.
All right, we're going to dive in and talk about your work because you have a very robust body of work. We're probably not even going to get to everything that I would have wanted to talk about today. So let's get started. Tell me and my listeners about dignity and care and how you're working to support healthcare professionals as well as patients and families.
So, I mean, the idea of dignity and care comes out of a large body of research that I, along with my colleagues, have been engaged in for nearly 35 years now, and we've been doing studies looking at various aspects of palliative care, end-of-life care, including a fairly large body of work that has looked at trying to really understand what we mean by dignity and how dignity can be operationalized in healthcare settings, how we can kind of make that real for patients and families and healthcare providers. So, I mean, the essence of dignity in care is this is a way of providing care that not only pays attention to the transactional things that we do with patients and families, but also the relational aspects, which means that we need to include, within healthcare, the idea that we see patients as whole persons, recognizing personhood. And the way in which that is helpful to patients, families, and healthcare providers is as follows. Nobody who enters into healthcare wants to be seen exclusively as a patient, even though the irony is that we in healthcare spend all of our lives learning how to look after patients. People don't like to be seen exclusively as a patient because a patient is kind of this generic designation. It's based on a particular, aberration in terms of the way their body is functioning. So it's a generic designation where personhood is entirely individual. So all of us like to be seen as whole persons. And when we're not, we suffer. The work of people like Eric Cassell, who was a wonderful American internist who had some really seminal pieces on the area of human suffering and wrote that people suffer when personhood is under threat of assault or disintegration. So dignity in care is an approach that is helpful to patients because it makes sure that we as healthcare providers do things that acknowledge personhood. It's helpful for family members because, again, like patients, no family likes to think that their loved one is being seen or treated in a generic fashion. I mean, it may be the case that, yes, they have a breast tumor or a prostate tumor or whatever the pathology may be, but to think that you are going to see somebody that I love and care about in terms of simply, physiology is kind of an assault. It's kind of an affront. And then lastly, I mean, how is dignity in care helpful to healthcare providers? Well, again, we've done studies that have looked at this issue. And what we find is that if healthcare providers kind of begin to see people exclusively on the basis of their ailments, then they become much more kind of robotic, much more transactional, much more disconnected from the pathos of what's happening in the clinical arena. And what ends up happening is that they start, acting in ways that are kind of mechanical, less feeling, less engaged. And in our own studies, what we found is that when healthcare providers actually recognize personhood, when they engage in issues related to patient personhood, they actually experience heightened job satisfaction. So I would say that the third element of dignity in care in terms of benefit to healthcare providers is this is a way of actually enriching your professional life and safeguarding you against professional burnout.
That's an interesting bonus that I think we overlook. So you practice in Canada, correct?
That is right.
Yeah. So the Canadian healthcare system, from what I understand, has a lot of the same challenges and issues that the U.S. healthcare system has. First and foremost, patients, I say patients, people come to us as people, we turn them into patients. You get a medical record number, or you get some sort of identifier. You get an ICD code. You get a diagnosis. And that turns them into patients, which immediately reduces personhood. And I know in the United States, because we're limited on time, we don't take enough time with our patients, or we don't have enough time. We don't want to get involved in their personal issues or their family dysfunction. It's easier to objectify a patient or depersonify, to dehumanize them a little bit and objectify them, because if we can reduce them to a set of diagnoses, comorbidities, it's a lot easier to push them through this system that we have. Would you say that Canada is very similar?
Well, I mean, I'd say that we face similar challenges. The healthcare systems, of course, are organized in very different ways. But the human experience of being a person who is then afflicted with some ailment that causes you to now make yourself or need to make yourself vulnerable to a large healthcare system. I mean, those dynamics are not dissimilar in many places around the world. And I hear you in terms of this idea that somehow it's easier, or in a large system, to kind of to sort of automate things to an assembly line, if you will.
Right.
If we can push people through the appropriate parts of the assembly line, at the end of the process, what we spit out hopefully is somebody who has recovered good health. The problem is that assembly lines work well for things like automobiles, because they're made of steel and Teflon. I had an article that I published many years ago, and the title was "The Secret Is Out: Patients are people with feelings that matter." So the truth is that even though in terms of things like efficiencies and the transactional elements of medicine, that kind of assembly line is very attractive, the problem is that human beings end up feeling assaulted. And even though I try and make the arguments that there's a human argument to be made here, there's some issues around compassion and kindness, that's kind of the it's trying to talk people into it on the basis of the rational, this is the right thing to do. But the stick argument would be that if we don't pay sufficient attention to this, And increasingly, I mean, we're at risk of not paying attention to this because the ways in which healthcare systems and large healthcare systems need to, be adherent to these efficiencies. We take some big risks. Um, First of all, patients are not as trusting if they don't feel a sense of caring and connectedness. And there's going to be a greater likelihood of discordance in goals of care. So that's a problem. As well, if patients don't trust you, they're not going to be as disclosing. You also will suffer, and by you, I mean healthcare systems will suffer risk of reputational capital. So if you look at the reason that healthcare practitioners or healthcare systems get into trouble, it's usually not because of medical misadventure. I mean, that's sort of a small portion of why there may be problems, but the vast majority of instances where patients complain or you end up seeing people, kind of going to court or litigating is because people just felt pissed off. They just felt like they weren't treated right. They weren't treated with kindness and compassion. And, I had a wonderful colleague of mine who used to say, patients will forgive you almost anything, but they won't forgive you lack of kindness. And so if we don't pay close attention to this, even though we say, well, no, we can't spend the extra time because, there are efficiencies to be considered, the fact is that it takes a long time to deal with complaints. Litigation is not a good thing. Reputational capital is not something that is easy to gain back. I'm doing currently a series of lectures across all of the Mayo clinics in the United States. And I remember having a conversation before we embarked on this kind of lecture series, and they're very interested in this kind of work. And I remember being on the line with a neurologist who was listening in, and at one point he said, "Listen, I'm very busy, and I don't have a lot of time for a lot of extra things." So I said, "Well, do you have enough time to ask somebody who they are as a human being, who they are as a person, so that you can give them the best care possible?" What we have coined the patient dignity question. He said, "Yeah, I think I can do that." So even if you have a small amount of time, if you use it in a mindful way, if you are focused, if you are not distracted, you can change the quality of the patient experience in a really profound way, as opposed to being very much kind of, going through the motions, processing the tumor. I remember one time asking a medical oncologist about, the protocol for treating breast cancer, and he leaned back in the chair and he closed his eyes and he just kind of rattled off the algorithm. He said, I could do it in my sleep. I would only need to be semi-conscious to still be able to rattle off the algorithm. But dealing with patients, providing not just what I would refer to as health care, but health caring, that's a whole different issue. And that takes real skill.
I love what you're saying, because what you're talking about is what patients want. They want a skilled practitioner. They want a skilled clinician. Absolutely. Right? You want to trust your doctor and have confidence in his skills. But they also want to see engagement and investment in the relationship between the clinician and the patient. And they want to see compassion. I think that's a huge investment. It falls back under that big term, bedside manner.
Well, very much so. And somehow medicine has kind of at some point kind of taken or evolved to a place where we begin to lose sight of the importance of connectedness. We forget about the fact that, human connectedness makes a profound difference. And just at the risk of that sounding too touchy-feely, there have been wonderful studies that show that there was a study, for example, by a woman named Kelly Trevino, who looked at suicidality in young patients with advanced malignancies, and found that suicidality was most highly correlated with the strength of the relationship between the patient and the healthcare provider, even over and above psychotropic medication. So these aren't just kind of subtleties. I mean, we tend to think of this as kind of, the niceties of care. We do this if and when there is time. But the truth is, if suicidality is most predicted by the strength of relationship, then this stuff that we're talking about now, makes the difference between life and death. So these are profound skills, which is why, many years ago, I published a piece in I think it was the British Medical Journal, called The ABCDs of Dignity Conserving Care. And it was saying that, and it outlines how attitude, behavior, compassion, dialogue that acknowledges personhood, that these are core efficiencies. They're not the niceties. These are core efficiencies if you want to work in healthcare. And if you say, well, I'm really not interested in that, then, maybe, the automobile industry, lends itself very well to people who are interested in assembly lines.
You say that so respectfully. And I will say it the unkind way. If this is not work that you are suited to, then you should find something else to do.
This last year, the Dean of Medicine asked me to give the what we call the white coat ceremony address. So this is a speech that is given to the medical students when they're first coming into medicine. Their first day of medicine, they arrive and all of their family is invited, and it's a big deal. And one of the things, amongst many others, that I say to them in this speech is, strive to be more than human body mechanics. Strive to be healers. And the other thing that I said to them is, patients won't care what you know until they know that you care.
Oh, very good. Say that again.
Patients won't care what you know until they know that you care.
I hope you're enjoying this episode. We're going to pause for just a minute. My guest has more to share.
This episode is being sponsored by Care Boss, the latest book by Jennifer O'Brien. More than 54 million Americans are serving as unpaid caregivers for family members, friends, or neighbors with serious illnesses. Very few have received the training, guidance, or emotional support they need to succeed in this role. Care Boss, the newest book by healthcare leader Jennifer O'Brien, fills this need by identifying and empowering the family caregiver as the leadership position it is. Jennifer shares her motivation for writing Care Boss.
I wrote Care Boss because I have been a serial family caregiver and I have been a serial CEO in healthcare. And it occurred to me that the family caregiver position is indeed a leadership position. I would go so far as to say it is a leadership position of greater importance than the CEO of a Fortune 500 company, because this is your person.
Jennifer writes with compassion and hard-earned wisdom. Readers will appreciate the empowerment and camaraderie they find in the pages of Care Boss. Care Boss is more than just a book. It's a workbook and organizer that enables family caregivers to lead their loved ones' care sensitively and effectively. You can find Care Boss at your local indie bookstore or on Amazon and at jenniferaobrien.com.
I want to talk more about dignity, and I want to talk to it as it holds a place in palliative care, because all of hospice contains palliative care. And now, of course, there's a huge upsurge in palliative care as a specialty here in the United States, where it's a standalone. One of the tenets that you share in your teaching is the importance of dignity in palliative care. Tell me what that means to you and why you feel that that's essential to the care of people who have serious illness.
Okay. Well, again, my background is in psychiatry, but as well, I am a researcher. So all of the things that I have introduced into the literature are really empirically based. It's not that I sat at home one day and said, dignity would be really cool. We've got to kind of add that into the recipe of palliative care. The way it came about is as follows. We had been doing some studies on things like desire for death and will to live, and this is decades before any legislation in Canada around medical assistance in dying. And at that time, our attention was drawn to what was happening in the Benelux countries, and in Holland, where, for instance, there were practices around euthanasia and assisted suicide. We then discovered what turned out to be a really important study in my research career, and this was a study published in The Lancet I think it was in the early 1990s by a gentleman named Paul Vandermas, and they looked at, so that they'd been commissioned by the Dutch government to look at the prevalence of what they called MDEL, or medical decisions to end life, and reported that somewhere around 4% of Dutch patients were dying as a result of euthanasia, so a lethal injection given by a healthcare professional, and less than 0.5% were dying as a result of assisted suicide, which is a prescription for a drug that the person takes at a time of their choosing that will result in their death. That was very interesting. But it wasn't really what we were most focused on. We wanted to know why. Why is it somebody might lose their will to live or have a heightened desire for death? That's really why we started to study those things, is because we thought, if we can understand why somebody no longer wants to live, that must provide some insights about better palliation. I mean, is there something that goes on that undermines a person's will to live that we can be more attuned with, so that we can attend to end-of-life care in a more effective way? So the Vandermas study then went to the death record of all these people who has died as a result of euthanasia, assisted suicide, and identified the physicians who'd been involved, and then spoke to those physicians and reported that, according to these Dutch physicians, the most highly cited reason as to why their patients sought out a hastened death was lost sense of dignity. More so than pain, more so than, what they call tiredness of life, unworthy dying, loss of dignity. And yet, even though that was interesting information, it wasn't directly from patients themselves. And we didn't really have a clear handle on what these Dutch physicians meant by it. So we began then a series of the first empirical studies on dignity in the terminally ill, and have many publications in the literature now that we have contributed to that. So when you say to me, well, what do you mean by dignity in the terminally ill? I say, well, what I mean by it really is irrelevant. It's what the data tells us that it means, that matters. And we know that one of the most ardent predictors of sense of dignity in our data is how people perceive themselves to be seen, appearance. So, which really turned out to be, for me, was kind of an epiphany. This idea that good palliation is not just what you do to patients or do with their families. It is about our perceptions as a healthcare provider. So our attitude, our disposition, the way that patients experience us appreciating them or not appreciating them, is the most ardent predictor of sense of dignity. That's a pretty heady finding. It's quite extraordinary, because it says that your attitude at the bedside is indelibly shaping each and every clinical encounter. In other words, if and I published actually a separate paper on this from the main paper was published in The Lancet. A separate paper that I published was in the Journal of Clinical Oncology, called Dignity in the Eye of the Beholder. And even though it kind of uses this metaphor, it's based on empirical data. And metaphorically, what that article says is that patients are looking in the eye of the healthcare provider for a reflection that will affirm their sense of self, their sense of personhood. In other words, if you see, the totality of who you are, an affirmation of who you are reflected in the eye of your healthcare provider, you're going to feel like, I'm still me. If all you perceive is a problem checklist or a differential diagnosis, you feel, I have become my illness. I am nothing more than my illness. And we have data that shows that for patients, no longer feeling like the person I once was is a profound existential question that they grapple with. So that's the first kind of empirical insight in terms of what I understand dignity to mean. The second, and it turned out to be even richer and more detailed, we did some very deep dive qualitative studies on dignity in the terminally ill and developed what is now referred to as an empirical model of dignity in the terminally ill. And I'm not going to go into all of the detail. I mean, it's quite complex, but it's out there in the literature. And essentially, what it does is it says, if you want to understand dignity in terminal illness, the model shows you all of the things that can influence sense of dignity. Some of them are mediated directly by the illness. We call that, illness-related factors. Some of them are external to the individual. So, the psychosocial, or this, what we call the social dignity inventory. So privacy counterbalanced by support, care tenor, your tone of care as a healthcare provider. And then the third category has to do with really the psychological and spiritual wiring of that individual. Everything from, the roles that they continue to preserve, the things that they find meaning in, the construct of generativity, which we introduced, which really is about, do I feel like my life will have made a difference, that there will have been a ripple effect as a result of the fact that I lived, that I was here? So I know it's a bit of a long-winded answer, but those are the things that I think about when people say, well, what do you mean by dignity? I mean, the dictionary definition is to be deserved of honor, respect, or esteem. It's not a bad definition. The empirical findings are the ones that I shared with you.
It all seems to center on identity, acknowledging a patient's identity, respecting it, preserving it as much as possible. So I'm always impressed with patients and how their identities have changed once we add in this role that they begin to play as a person with an illness, right? And because in serious and life-limiting illness, the pieces of their identity that they've trusted, that they've relied on, that are hardwired in, that they would never dream would change, are changing, dropping away, falling away. The ability to be physically active, wage-earning roles, relational roles, decision-making roles, all of those things fall away. So treating someone and respecting their dignity is a way of affirming and validating their identity.
Yeah, and I love the word, to affirm or affirmation, because it's powerful, and it allows us to recognize things that are intrinsically and innately part of who that person is. And the challenge, as you point out, illness, is assaultive in so many ways. It takes away so many things. And in the work that I do, and certainly when you're dealing with people who are critically ill, I'm intrigued by this idea of what are the things that illness cannot touch? And what can we as healthcare providers and as family members, what can we do to somehow try and safeguard those things? I remember looking after a woman years ago. She was kind of this matriarch of her family. And certainly as she became ill, there were many things that illness took away, that she could no longer, she no longer had her mobility to the same extent. She no longer could kind of do things in the same way that she had usually done. But what was intriguing, and it just sort of put a smile on my face. I think her family was a little bit scared of her, to tell you the truth, because she could be quite exacting. And I remember even, she was on her deathbed, she would wag her finger and have everyone scurrying. And I thought to myself, good on you. The core, the essence of personhood was intact. Of course, I mean, all of the various things that she could no longer do were beginning to vanish. But that's the kind of the segue is from doing to being. And, being is something that sustains for a very long time, almost until, consciousness begins to wane. So this is why, when we introduce things like dignity therapy, which we may talk about a little bit later, in spite of the fact that people still, can't do many things, they can still reconstruct their story. They can tell you the things that matter to them. They can leave behind lessons that are going to make a difference to the people that they love and care about. And, those are no small issues. I mean, those are pretty profound. And enabling them to do that is extraordinary.
Dr. Chochinov, thank you so much for being my guest today. There's so much to unpack out of your work, so I'd love to have you back for a second conversation. What do you say?
I'm game. I look forward to it.
Awesome. So we'll see you next time. Thanks for listening to the Heart of Hospice podcast. Check out our sponsor in the show notes, and please leave a rating and review on Apple Podcasts. We would appreciate it if you would share this episode with your friends and family and anyone who needs to know more about hospice. Connect with us on Facebook, Instagram, and LinkedIn. And remember, no matter who you are or where you are in your hospice journey, you are the heart of hospice.
This is the Whole Care Network. Helping you tell your story one podcast at a time.